So in this chapter, we'll be dealing with RH isoimmunization. So the RBCs, they carry a number of surface antigens. So capital C, small c, capital D, small d, and capital E and small e. Okay, all of them are collectively called the RH factor. They're present on, the genes are present on short arm of chromosome 1. Okay, so the D trait, it is heterozygous. So basically, if one capital D and one small d are there, even then the baby will be RH positive. Okay. So RH compatibility, it is an immunological disorder. So the mother produces antibodies against this blood group factor in the red cells of the fetus, which she does not possess. So basically, factors influencing RH isoimmunization. See, you will be talking about fetal-maternal hemorrhage. That is the main cause in which the mother gets sensitized. So duration of pregnancy. See, RH antigen expression is well developed as early as 32 days of gestation. Okay, fetal-maternal hemorrhage is a normal occurrence during pregnancy, which facilitates the entry of fetal blood cells into maternal circulation. Both frequency and magnitude of the bleeding increase as pregnancy advances, and maximum fetal-maternal hemorrhage is seen at the time of delivery. So what are the events that precipitate fetal-maternal hemorrhage during pregnancy? So basically, in the antepartum period, you can have ectopic and molar pregnancy, preeclampsia and eclampsia, antepartum hemorrhage. Okay, it increases the risk of fetal-maternal hemorrhage. See, antepartum hemorrhage can be very severe, so that is why to see the degree of fetal-maternal hemorrhage or the severity, you use Kleihauer-Bettkes test. In multiple pregnancy, okay, in invasive procedures such as amniocentesis and chordocentesis, external Catholic version, fetal demise and maternal trauma. So all of them. So external Catholic version, you can have multiple pregnancies, antepartum hemorrhage, you can have invasive procedures, okay, like amniocentesis, chordocentesis, and chorionic villus sampling, ectopic and molar pregnancy, preeclampsia, eclampsia, all this. And in labor, while doing a C-section, you can cause fetal-maternal hemorrhage, while doing manual removal of the placenta, while doing massage of the uterus, while doing early ligation of the cord, or if you use ergometrine, which may squeeze the fetal cells into maternal circulation. Okay, so quantity. So basically, on average, the bleed may not be more than 15 ml in a term pregnancy. So 15 ml of RBCs, that is 30 ml of fetal-maternal hemorrhage. Okay, so just remember that. ABO incompatibility, it actually protects against RH isoimmunization, because in ABO incompatibility there is rapid clearance of fetal cells from the maternal circulation so that they are no longer immunogenic. So mechanism, basically, when there is fetal-maternal hemorrhage, what happens is the fetal RBCs, they circulate for 120 days in the maternal circulation, and then they undergo degeneration and are removed by reticular endothelial system, where the antigens are released and then antibodies are formed. But the antibodies are formed are IgM type in the first sensitization, but IgM antibodies which are formed, they can't cross the placenta. So the first pregnancy, the baby is safe, but in the second pregnancy, when there is subsequent sensitization, IgG antibodies are found, which can which can cross the placenta and cause hemolysis in the baby. Okay, so that is secondary immune response in the second pregnancy. So primary and secondary. So first pregnancy does not get sensitized unless there is substantial fetal-maternal hemorrhage or if RBCs are removed faster than usual. So again, moving on to pathogenesis of hemolytic disease of the fetus and newborn. See, what are the effects on the fetus? Basically, you will have hemolysis happening, right? So because of hemolysis, you can have jaundice. Okay, so hemolytic anemia. So because of hemolytic anemia, you can have severe anemia, and this again causes stress on the heart, so that can lead to hydrops fetalis. Okay, so then again, because of severe hemolysis, to compensate, what the fetus does is the bone marrow and the liver, they perform hematopoiesis. Okay, so erythropoiesis. So this causes hepatosplenomegaly and basically erythroblastosis fetalis. Okay, so that is one thing. Basically, because of increased jaundice as well, because of increased severe hemolysis, the bilirubin level increases. So in premature baby, the bilirubin is not cleared from the circulation. So the excess unconjugated bilirubin diffuses into the tissues with high lipid content, such as the neurons. Okay, especially it crosses the blood-brain barrier and affects the mitochondrial function, leading to neuronal cell death. So basal ganglia is most commonly affected, so that leads to kernicterus. The baby presents with cerebral irritation, convulsion, switching, and spasticity, and difficulties with fine motor skills. Okay, so hydrops fetalis, what all can you find? See, to diagnose, you need 2 out of 4. Okay, what are the 2? You can have pericardial effusion, pleural effusion, or peritoneum fluid, so ascites, and subcutaneous edema. Okay, so all out of these 4 criteria, don't look at this. So out of these 4 criteria, pleural, pericardial, peritoneal, so ascites and subcutaneous edema, you need to have 2 out of the 4. It is an ultrasound based diagnosis. Okay, and you also see a Buddha sign or a halo over the scalp of the baby. Okay, the placenta is pale and edematous with swollen villi. That is important. Next, methods to identify fetal-maternal hemorrhage. You have something called Kleihover acid dilution technique. So as the name indicates, you are adding acid buffer, so acid citrate phosphate buffer to the blood, okay, blood smear. So what happens is you are decreasing the pH. So basically at this decreased pH, adult hemoglobin, it escapes out of the cells and this leaves out non-staining ghost cells, whereas fetal hemoglobin does not elute from the red cells at this pH. So you can evaluate for large volume fetal-maternal hemorrhage as seen in abruptia placenta or antepartum hemorrhage to decide the dose of anti-D immunoglobulin to be given. Okay. Next, based on this, see, 5 fetal cells in 50 low power fields represent 0.25 ml of fetal-maternal hemorrhage. Next, Rosetting test. So Rh positive cells, okay, Rh positive cells which are coated with antibodies, so they form rosettes when the Rh positive indicator cells are added. And flow cytometry also you can use. See, methods to assess the presence of Rh antibodies. Okay, so what are they? You have indirect Coombs test, which is done on maternal blood. Okay, so basically you take known positive RBCs which have anti-D on them, antigen, and then you add the maternal blood which might have antibodies. So if the antibodies also bind and the complex is formed, then indirect Coombs test is positive. So then again you can do it after serial dilution to know the titer. Okay, then direct Coombs test. So basically directly in the fetal blood you are doing this test. Okay, you are detecting the anti-D antibodies. Okay, in direct Coombs test. So directly antigen you are detecting. Next, prevention of RH isoimmunization, so postpartum prophylaxis. See, whenever an RH negative pregnant woman delivers, a cord blood sample is taken. If the baby is RH negative, no problem. Then if the baby is RH positive, you need to give anti-D to the mother to prevent isoimmunization. See, 30 ml of fetal-maternal hemorrhage is 15 ml of RBCs. So that is why you give 300 μg of anti-D immunoglobulin to neutralize this amount. Okay. So administration of anti-D immunoglobulin should be done within 72 hours of delivery. Next, basically antepartum see, this is postpartum prophylaxis after delivery. So antepartum prophylaxis, what you have to do is at 28 weeks, you have to give a dose of 300 μg of anti-D. And repeat dose is given within 72 hours after delivery of the Rh positive infant. Okay, so that is anyway postpartum prophylaxis after the delivery, but at 28 weeks you do it. See, first trimester pregnancy wastage, so following an induced spontaneous miscarriage or ectopic pregnancy or molar pregnancy, the mother should receive anti-D, but 50 μg is adequate, no need of 300. 50 μg if it is adequate if the pregnancy is terminated prior to 13 weeks. But second trimester miscarriage, again give 300 μg. Following amniocentesis invasive, 300 μg. Antepartum hemorrhage, do Kleihover and based on that you give anti-D. Okay, so 300 μg of anti-D is administered for every 30 ml of fetal whole blood or 15 ml of fetal RBCs. Okay. Next, management of Rh negative non-immunized woman. See, if the father is positive, mother is Rh negative, then do indirect Coombs test at second and third trimesters. Okay, see, if it is antibody negative, okay, then give at 28 weeks antepartum, do fetal surveillance, ultrasound assessment, and deliver at 40 weeks. Okay, deliver at term. So collect the cord blood samples. Okay, again if the fetus is Rh positive, you have to give anti-D to the mother. Okay, so 300 μg within 3 days of the delivery. But if it is antibody positive at any period of gestation, you need to manage as a sensitized patient. So this is routine antepartum and postpartum prophylaxis you will do at 28 weeks and within 3 days, 300 μg anti-D. But in case of sensitized woman, what you do is you think about previous history of affected fetus. If the previous fetus is not affected, Then first what you do is you check the antibody levels. Then if the antibodies are positive, you check for fetal anemia. If fetal anemia is there, you try to grade the anemia as mild, moderate and severe, and you plan accordingly. Okay, this is what you need to remember. See, if there is previous history is negative, then you check the antibody levels. If the antibody levels are below the critical titer of 1:16 or 1:32, then you continue the pregnancy, deliver at term at 40 weeks, but also you give antenatal corticosteroids, and again you keep assessing the baby rate, so ultrasound and all these tests, and fetal surveillance. Okay, and middle cerebral artery studies, Doppler, you do it for peak systolic velocity flow assessment, so it is an indicator of anemia. Okay, so if there is no fetal anemia also, you keep monitoring with MCA Doppler. Okay, but if antibody level is more, okay, gestational age is greater than 34 weeks, you deliver. Don't think of anything else. See, if gestational age in an RH isoimmunized pregnancy is greater than 34 weeks, you immediately deliver. If it is less than 34 weeks, then you give a transfusion, intrauterine blood transfusion, and then you deliver at 34 weeks. Okay, again, if previous history is positive, you don't need all these titles, blah 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 blah. But okay, you don't need this part, but what you have to do is this whole part you have to initiate these investigations 10 weeks prior to the time at which incident occurred in last pregnancy. Okay, 10 weeks prior you have to do all this. So again, ultrasound, middle cerebral artery studies, amniocentesis and chordosynthesis, intrauterine blood transfusion, deliver at 34 weeks. Okay, so that is what is there. And in delivery, you need to remember that it should not be allowed to go beyond 40 weeks, as this increases the chance of fetal-maternal hemorrhage. After delivery, do early cord clamping. Immediately clamp the cord. Then next, milking of the cord and manual removal of the placenta should be avoided. This might increase fetal-maternal hemorrhage. Avoid using ergometrin again. Okay, so again, cord blood samples are collected for blood grouping, RH typing, hemoglobin and hematocrit, bilirubin, direct Coombs test, and peripheral smear. Okay, so again, non-invasive methods. So basically, RH antibody titer. So again, significantly you take it as 1:16 or 1:32. Then again, actual antibody levels. See, if the level is less than 4 international units per ml, less than 4, then fetal hemolysis is mild. 4 to 8, moderate, and warrants delivery by 38 weeks. Greater than 8, it is severe hemolysis. Okay. Then ultrasound evaluation of the fetus. So again, it is important in determining laboratory values such as amniotic fluid, bilirubin levels, and all that. Okay, so for hydrops also you do ultrasound. Okay. Next, early signs of fetal anemia. So again, you can have hepatosplenomegaly, polyhydramnios, large placenta, increase in the umbilical and intrahepatic vein diameters. Late findings of fetal anemia, so pleural and pericardial effusion, scalp edema, so the Buddha sign, increased skin thickness, okay, skin edema subcutaneously, and enlargement of the heart. So Doppler velocimetry of umbilical and portal veins, normal portal venous flow is smooth, whereas in presence of anemia, the venous waveform, it bears a sawtoothed appearance. Okay, that is important. And MCA Doppler, so again you do it to assess anemia. A value above 1.5 MOM, multiples of medium, is diagnostic of anemia. So again, you keep repeating it if it is negative, less than 1.5. Then again, what are the invasive methods? See, now you currently don't do amniocentesis and examination of amniotic fluid because you have MCA Doppler. So basically, what used to be done is you used to take the amniotic fluid and you used to do spectrophotometry analysis of the fluid for bilirubin. Okay, again, so antibody titer, if it is greater than 1:16, so significant, or if there is previous history, then you used to do. So currently, it is replaced by MCA Doppler. So basically, what happens is in the presence of bilirubinoid substances, absorption takes place at a peak at an optical density of 450 μm. Okay. So in the absence of bilirubinoid-like pigments, the spectrophotometric analysis shows a smooth, unbroken line. Okay, whereas when such pigments are present, bilirubin, there is a typical humping of the line. Okay, so here you can see. So normally it is a straight line, but when bilirubin is present, there is a humping with peak at 450 μm. Okay, that is important. So optical density and wavelength. Then the difference between the expected slope and the peak of deformation. So this you will plot on a Liley's graph. Okay, So Lilly's graph, originally it had 3 zones, but later Queenan proposed 4 zones modification. Okay, so basically in Lilly's graph, what happens is, let us just see here. Okay, so you have optical density here again, but weeks of gestation. So based on this, zone 1, zone 2 and zone 3. So zone 1, the fetus will only have mild disease. Okay, amniocentesis should be repeated again. Zone 2, again moderate risk. So repeat after 1 week. Values in zone 3 is a severely affected fetus. So again, think of intrauterine transfusion or delivery. Okay, so that is what you need to think of. Next, intrauterine transfusion, it is generally performed between 18 and 34 weeks. So basically, less than 34 weeks, if there is severe anemia, you think of fetal transfusion. So it is done under ultrasound guidance. So you give O blood group and Rh negative, so O negative and cytomegalovirus negative blood. It is cross-matched against the maternal blood and collected in the previous 72 hours. Okay, the aim is to increase the hematocrit to 40%. Cells are packed in a hematocrit of 75 to 85% to prevent volume overload in the fetus. You give the blood at the insertion of the umbilical vessel in the placenta, okay, or within a loop of the cord. So again, there's always a risk of cord hematoma, abruption, preterm labor, all this. Next, you can also give intraperitoneal transfusion. So through the abdominal wall, a catheter is placed into the peritoneal cavity and transfusion is given at rate of 1 to 2 ml per minute. So see, weeks of gestation minus 20 into 10. Okay, that is the volume of blood you have to give for intraperitoneal transfusion. You also have intraperitoneal transfusion. Other than that, intravascularly you gave it to umbilical vein or intrahepatic portal vein, and intracardiac also you can give. Okay, and then delivery. So again, greater than 34 weeks, deliver. Less than 34 weeks, transfusion, and then deliver based on severity of hemolysis. Management of the newborn. So again, entire Rh positive blood of the baby you will replace with Rh negative blood. Okay, so especially exchange transfusion is required if cord blood hemoglobin is less, serum bilirubin is more, and obvious clinical erythroblastosis.